Okay, let's pull up another case. Go to the patient list. And so what you have to do on this is I want you to put it in the cardiac plane. So you can do Alt-click on the mitral valve. That'll center it right there on the mitral valve. You're going to take this up and down line, this purple line, and you're going to drag it over here. So this plane is towards the apex, parallel to the interventricular septum. The two-chamber view happens to be over at the right-hand lower here, right? So you see you're at the mitral valve. You drag this down to the center of the mitral valve. The apex is down here, so you need to angle this down so you get a true long axis. Okay? So is everybody with me? So now you've got your short axis here. You got your mitral valve. And you can scroll all the way to the apex. Let's go back to the mitral valve. And let's review the anatomy here. You got this superior commissure, inferior commissure. What is this right here? Which segment, which leaflet is this? Toss up. So that's the anterior, so that's A1. A3. And so now P1, P2, P3. It's that easy. It's way easier than TEE. Like TEE is really confusing. But CT, like you can see it all. Oops. So it's not that hard. That's why radiologists can do it. It's easy. Okay. So if you're doing tear or edge-to-edge repair, you have to be able to collapse. You have to grasp both the anterior and the posterior leaflet. So when you look at these images, you could see if you had a big chunk of mitral annular calcification here, that might be a problem for clasping that posterior leaflet. And that's why you want to talk about that. The other thing that you can do is you can measure the length of the leaflet, and as you saw from the FDA and the device manufacturer, they have different devices that are better for longer or shorter leaflets. Sometimes they'll put in multiple clips of different sizes or the same size. I don't know how they figure that out. It's probably, you're looking at it on the TEE and you say, okay, that's what I'm going to do. But if you wanted to measure it, you can, again, on the mitral valve say, hey, typically the problem is some people have very diminutive posterior leaflets of the mitral valve. It's either eroded away or they have a very long anterior leaflet. And those people are not good clip candidates because there's not much of a posterior leaflet to grasp onto. And so on the CT, you can go to the A2 and the P2 and measure that P2 length and say, hey, the P2 valve on this one is 12 millimeters, that's okay, but you could imagine, or I could imagine, maybe you can't imagine, that if this leaflet was only 5 millimeters, there's not much to grasp when you're in there on the TEE with a catheter to grab onto that to clip to, so that might be a problem. And I've learned that if cardiac surgeons can understand something, there's a chance interventional cardiologists could understand it. Not much, but just a chance. But if you can teach a surgeon to do it, an interventional cardiologist has half a chance of learning it. So I work with the cardiac surgeons first, and then I port it to the cardiologist, but just kidding. But you can see here that, as Cam mentioned, there's kind of a blowout aneurysm of one of the sinuses. So it's the left sinus of Valsalva, and you see all this black stuff or gray stuff. The gray stuff is all thrombus in the sinus, right, Cam? And so the question is, what's going on with the LAD? So if we have the LAD, you can see here's the LAD on top of this that's moved up. If you did the cath, here I'll put this in MIP, you can see how this LAD is displaced upwards, right? That if you did a cath, you'd see the vessel going up and you'd have this area that's basically not filling.